Knee osteoarthritis remains one of the leading causes of disability worldwide. For many patients, the treatment options are limited to conservative therapy or total knee replacement, with very little in between. But one of the most interesting developments in the recent year has been Genicular Artery Embolization, or GAE, which is an image-guided endovascular procedure that's reshaping how we approach chronic knee pain. I'm Dr. Anuj Shah from Apex Heart Vascular, and I want to take a few minutes to discuss the scientific rationale, the evidence, and patient selection for GAE, because it's one of the most exciting areas where interventional radiology, pain management, orthopedics intersect. So what is the rationale and pathophysiology? We have known for years that pain in osteoarthritis isn't just mechanical, it's inflammatory. Histologic and imaging studies shown that in moderate to severe osteoarthritis, the synovium becomes hypervascular, forming a web of fragile new vessels around the genicular arteries. These abnormal arteries carry inflammatory mediators and sensory nerve fibers, perpetuating the pain cycle. GAE targets this exact mechanism to selectively embolize small abnormal genicular branches while maintaining normal perfusion to bone and surrounding tissues. What are some of the evidence? In terms of data, the Eureka trial in 2022, a multi-center randomized study demonstrated statistically significant reduction in both VAS and WOMAC pain score at 6 and 12 months compared to the baseline. The Okuno sham control randomized control trial further validated this finding, showing an average 50 to 55% reduction by 1 month post-procedure with sustained improvement that lasted beyond a year. MRI-based studies, including work by Okuno and Lee and colleagues, show objective reduction in synovial enhancement and hypervascularity after embolization without evidence of cartilage damage or ischemic changes. Long-term observational study data such as the Japanese cohort published in Journal of Vascular and Interventional Radiology showed 80% responders maintained meaningful pain relief out to 3 years after a single treatment. Collectively, this gives us level 1 and level 2 evidence supporting GAE both as effective and durable in appropriately selected patients. So how do we select patients? We typically consider GAE for Kellgren-Lawrence grade 2 to grade 3 disease, which is grading on the X-ray, showing at least moderate or moderate to severe osteoarthritis, where conservative therapy has failed, but surgical intervention is either not yet warranted or not possible. This includes patients with medical comorbidities, advanced age, those wishing to postpone arthroplasty. What about bone on joint disease, or KL grade 4? That can still experience improvement, though the benefit tend to be less robust or shorter lived. What about procedure details and safety? The procedure is performed via pedal or femoral access under fluoroscopic guidance using microcatheter and using 100 to 300 micron microspheres or using imipenem cilastatin antibiotic combination, which works as an embolic agent. It's outpatient, typically completed within 90 minutes. Complications are exceedingly rare. The only common complication occasionally seen is transient skin warmth or small patch of discoloration that does tend to resolve spontaneously. No major adverse events have been reported in the published trial. In conclusion, gone are the days when patient had only 2 options: live with pain or sign up for a total knee replacement. Today, like everything else in modern medicine, we are recognizing the treatment isn't one size fits all, and GAE is a perfect example of that. For patients who are too frail, too high risk from a cardiovascular standpoint, anesthesia standpoint, or a vascular standpoint, who have had a prior DVT, GAE can offer a meaningful relief without the risk profile of a major surgery. But it doesn't just stop there. Even patients who are simply hesitant to undergo a knee replacement, or those who are concerned about the rehab, the time of work off, the uncertainty of the outcome, those patients may benefit tremendously from starting with a minimally invasive approach. And that's what GAE is: durable, outpatient, minimal downtime, and guided by imaging, not guesswork. The key is careful patient selection. Not every patient is a candidate, but for the right patient, this is just in the stopgap. The powerful, evidence-supported intervention that belongs in the same conversation as knee replacement surgery. As vascular and interventional specialists, we have a responsibility to stay engaged in that conversation and to bring these options to the table when they are clinically appropriate. The remarkable example of how endovascular science continues to evolve beyond the traditional vascular system and into restoring mobility and function for patients who truly need this option.